Hi everyone, my name is Dr. Who, and today I have the privilege of talking about sensory disturbances with multiple sclerosis. So beyond the focus of many office visits talking about disease-modifying therapies to prevent future relapses and slow down progression, it's extremely valuable to be talking about how to treat the symptoms that are due to the past and existing injury to the brain and spinal cord. And actually, a significant proportion of MS patients suffer from sensory disturbances and pain. And some studies have actually shown that up to 50% of MS patients suffer through such symptoms. So beyond that, it's important to address, just given the suffering that can happen as a consequence, as neuropathic complaints can disrupt sleep. It can consume a good amount of energy to be able to compensate every day. It definitely can affect the mood, and lastly, it can affect even changes in appetite. So a little bit about the basics about the sensory system and why it exists. Basically, it's so that we can experience and perceive the outside world when it functions well, right? When it functions properly, it does serve a protective role. So normally it recognizes triggers and can serve as an alarm. And this so-called good functional pain signals to remove the body from any further injury. And this picture is to kind of help delineate the pain pathway of when things work well, where there are pain receptors in our extremities and body that detect an irritant, and then signal messages up through the peripheral nerves up to the spinal cord, where there's then a transmission of neurochemicals that further release and relay the pain upwards to the brain. Up at the brain, we have specific structures that then process the information. So key parts, including the thalamus, which is a major command center. There's the somatosensory cortex that is responsible for registering which part of the brain is suffering from what. There's the frontal cortex that helps kind of contribute to higher level processing, especially as it relates to restraint and kind of response. And lastly, the limbic cortex is responsible for the emotional processing of pain. So once our brain receives these messages, it does normally provide a protective response, right? So it could actually instruct the muscles to move away from the irritating object, or it can actually turn off conscious awareness because it just doesn't want to perceive the outside factor anymore. However, sensory symptoms do occur when there's dysregulation and subsequently due to the damage from MS when the brain and spinal cord erroneously process information. So what type of abnormal sensory disturbances can happen? We talk about neuropathic complaints, or basically pain due to nerves. And when due to MS, it's again caused by the injury to the myelin, or the outer coating of the nerves, that just messes up the signaling pathway, the pathway that we just reviewed. And as a result, the stimuli can be misinterpreted as different sensory disturbances. So everyone's MS is different. Everyone's symptoms are a little bit different. So this slide basically kind of points to how the sensory disturbances can be perceived. Some describe an ice-cold sensation, some describe pins and needles, some even describe burning, right? So having these descriptors are very important to convey to your provider because it can point us to the right cause and appropriate types of treatment. I just want to spend a couple of moments talking about certain specific pain syndromes in MS. The first is trigeminal neuralgia. The older term is tic douloureux. And basically what this is, it's a sharp, stabbing, shock-like pain that usually goes from 0 to 60 really fast, can last seconds or minutes, and then just go away. Or some people actually have an underlying pain that just kind of surges. It typically happens on one side of the face, usually in the V2 or the V3 distributions of the trigeminal nerve, the maxillary branch, the mandibular branch, and can be triggered from, talking, chewing, just anything kind of, even smiling, activating that area. And again, this is due to myelin being disrupted by MS covering that trigeminal nerve. The second type of pain syndrome, or sensory sign, is Lhermitte's. And basically what this is, it's an electric jolt that kind of shoots from the back of the head and potentially down the spine and through the arms, brought whenever you're kind of bending your neck forward. and that's caused by pulling of the myelinated tracts in the back, again, that are injured and are responsible for vibratory and other sensations. Another type of neuropathic condition in MS is that MS hug. And so unfortunately, it's not as nice as it sounds. It's a squeezing sensation that's kind of almost like a tight band hugging the chest that can actually sometimes be confused or even concerning for a heart attack. And then lastly, patients can describe just, numbness or kind of loss of sensation, dysesthesias or paresthesias, where it's just basically an abnormal sensation than what you would expect to the outside world. So again, people can describe prickly sensation, pins and needles, even buzzing sensations throughout their body. And I will just kind of take a quick note. These sensory disturbances are worth noting, but there are different types of pain and sensations like muscle spasms and spasticity and tightness that are not covered during this specific talk, but hopefully will be covered in another MS 101 session. And wrapping up the different types of sensory disturbances that MS patients suffer from, unfortunately, there are other types of neurological pain that might layer on top but are not due to MS itself. For example, headaches. So a lot of patients suffer from migraines, especially it's more common in women, ages 20 to 40. Tension headaches just due to stress, and definitely neck and back pain. For example, you can have kind of shooting sensations under your arms or legs, where there's nerves, pinched nerves that just kind of send shock-like sensations or tingling in your arms or legs. So why is it important to identify these sensory disturbances, right? Ultimately, we want to figure out a cause so we can intervene appropriately. So for some patients, new sensory symptoms that last at least 24 hours or more, or maybe associated with new neurological complaints, might actually signal a MS relapse, right? So definitely talk to your provider. Otherwise, chronic pain related to MS is fairly common and can be effectively managed with different treatments that we will discuss shortly. And lastly, there are other pain complaints like we just mentioned that are not necessarily due to MS, but can still be treated by a neurologist, like migraine or sciatica. Second, it's important to evaluate, once we identify the pain and treatments, whether or not our treatments are working, okay? So when we discuss treatments and how effective they are, we're looking for a decrease in one of three metrics. Those three metrics are, frequency of the pain episodes, how often are they happening? The second being the severity of pain, how bad is it? And lastly, the duration, how long is everything happening? So even though MS patients typically experience chronic long-term pain, it can be well managed with minimal impact on quality of life by reducing one of those three factors. Lastly, why it's important to identify these sensory disturbances, because we want to break this chronic pain cycle that this slide kind of shows. Pain affects every aspect of life, right? If pain limits movement, people are less active, they feel tired because they're deconditioned, and they just feel slow and sluggish. Pain can rob quality of life, as patients may feel, have negative thoughts and even feel depressed or anxious and have worries about what this means for the future. Consequently, our body responds to the neurochemicals, even related to mood, so that can actually further feed into the pain cycle. So we want to have the right words, have the right insight, so that we know what we are targeting for effective management. Right. So in discussing more about pain relief, again, the goal is to improve the overall quality of life, to make each day worthwhile. So there is a wide approach in terms of strategy. First, ultimately, we have to treat the cause, right? That's why we talk about our MS medications that affect the immune system and target to prevent future relapses and future lesions that might contribute to development of pain. Beyond that, we have medications that reduce pain and also non-medication options. So, the first topic of oral medications, a quick preface before we talk about medications that we can take by mouth. There is no such thing as one size fits all. Okay, every case of MS is a little bit different, so consequently the treatment is as well. The most appropriate medication really depends on other complaints, other medical conditions, definitely other medications that one might be taking if we're considering drug-drug interactions, and potential side effects that patients are willing to endure. With specific medications, there's also a great range in terms of dosing. Okay, so just because we tried a medication doesn't mean that we necessarily fail it if we're not at the appropriate number of mgs. The specific treatments that I'm about to talk about are incompatible with your disease-modifying therapy. Okay. And we'll talk largely about the antidepressants and anticonvulsants. And while I will be going through indications and side effects, I will comment that with side effects, it really is important to discuss with your provider and discuss on a case-by-case issue. It would be very overwhelming to go through all the potential side effects that the FDA is required to list, but there are certain ones that are a little bit more common that are worthwhile to kind of look into. Lastly, opioids or narcotics are actually not recommended for long-term use. There's concerns about developing tolerance, increasing side effects, and then possible addiction or overdose. Though they do have their role, it's not for long-term care of MS-related pain. So the first class of medications used to treat neuropathic pain are antidepressant and anti-anxiety medications. This, I need to be clear, this does not mean that the sensory disturbances are all in your head or psychiatric. Okay? Instead, the neurochemicals that targeted with these medications like serotonin and norepinephrine are actually the same neurochemicals that relay sensory messages. Right? So the first subset of mood medications are tricyclic antidepressants. I list three right here, amitriptyline, nortriptyline, and desipramine. The brand names are noted in parentheses. Again, they are used to treat depression. A lot of us also use them as preventative measures to decrease headaches. Beyond neuropathic pain, there can be also off-label use for irritable bowel syndrome. Again, even regarding side effects, you could potentially be scared off by this list, but I would comment even slowing down of the bladder. Some people with MS have overactive bladder at night, so they actually might want to discuss medications that make it less disruptive. Even in terms of drowsiness, if people are having insomnia, right? One of the intended side effects of these medications might be to help promote sleep to decrease further pain during the day. Another subset of mood medications are the SNRIs, or serotonin norepinephrine reuptake inhibitors. I list three here: duloxetine, and also milnacipran, and also venlafaxine. They are generally well tolerated. People actually might experience a little bit bump in their energy because it does act on norepinephrine, or that adrenaline feel good, get up kind of neurochemical. There could be slight side effects as it relates to changes in libido, but again, this is very case by case. Okay, great. And then moving on to anti-seizure medications. Again, borrowing from the concept where we can slow down electrical chemical changes that happen in seizures, we can also disrupt electrochemical changes that happen in pain. So these first two medications act on the calcium channels, gabapentin and pregabalin. And what they do is they basically modulate the calcium so that we inhibit the excitatory neurochemical release of things like glutamate or even substance P that can propagate pain. Beyond use for neuropathic complaints and seizures, there can be off-label use for restless leg. In terms of side effects, some people experience some leg swelling, a little bit of drowsiness, but again, there's ways to kind of discuss this with your provider to make sense of the maximal benefit versus minimal risk. These seizure medications affect the sodium channels, carbamazepine and oxcarbazepine, again, trying to lessen the irritable nerve signals that propagate. These, in terms of indications, I will comment they're very helpful for trigeminal neuralgia. Again, that facial sensation on one side that feels like a jolt lasting seconds. And then in terms of side effects, it would just be important to consider potential drug-drug interactions. Again, something to be discussing with your medical provider. Lastly, this group of anti-seizure medications also affect sodium, lamotrigine and valproic acid. And the reason why I group these together is that they can actually be helpful in terms of mood stabilization beyond the other indications. Okay. So transition from oral medications to topical medications. With topical medications, the hope is that we can actually target the medications to avoid the systemic side effects, right? So capsaicin cream is something that can target the small fibers. Your provider can also discuss specialized compounds where it's special mixes of the medications that I just mentioned, where we can minimize the whole body side effects. It can include, so these topical specialized compounds can include antidepressants, even antispasm, and even lidocaine as a numbing agent. And beyond medications, there's definitely things that I would quote unquote prescribe to minimize the sensory disturbances to make them more tolerable. Behavioral self-management, definitely in terms of relaxation with mindfulness and meditation, just kind of quiets down the nerves. Sometimes people find cognitive behavioral therapy, changing the perceptions around our sensory disturbances can also be very impactful. Ultimately, in terms of monitoring symptoms, it is important to avoid triggers, right? If we know that something's, or too much activity or even too much heat is bringing upon these things, trying to mitigate that by avoiding those potential triggers. And lastly, staying active definitely can reduce the impact, even distract, or even retrain the body beyond these sensory disturbances. All right, so in terms of this slide basically speaks to trying to think from the patient perspective. What would you want to know to be able to be a good partner in guiding the management, right? One of the first questions I could think that would be very relevant is, how do I know what treatment is the best for me? And I think it really boils down to having a meaningful dialogue with your provider and addressing the topics that we mentioned during this talk, and then being able to be open to adjustments and changes and checking in. Second question of, what do I look out for when I start these medications? Even in terms of benefit, right? Monitoring for improvement, again, in terms of severity, frequency, or even duration of pain. You might even notice improvement in functioning, right? Being able to move around more, better mood, better sleep. Those are subtle clues that the medications might be working well for you. And also, definitely, if you're not having to miss work, miss school, or just being able to do things more around the home, can signal that there's benefit. Then what about in terms of potential negative things? I think it is important to discuss the most common side effects with your provider, just so that you know what to be on the lookout for and when to reach out. It is important to also talk about doses and expectations, right? So some medications can be taken as needed, and others are every day as maintenance. It's also good to kind of talk about whether or not there's an up titration in terms of building up the dosing so that we minimize side effects and kind of get used to them. Also, if you want to come off medications, it's important to talk about potentially weaning down or slowly decreasing the dosing. And I'm trying to think, even in terms of how long it takes for medications to act, some of the antidepressants actually do take upwards of 6 weeks for there to be a good kind of steady state to be able to evaluate the full benefit of medications. The third question I would ask is just about safety monitoring and long-term use. The medications that I mentioned today are widely used and can be used long-term, though sometimes we do need to monitor liver and kidney function just to make sure that our bodies can clear out the medications appropriately. And I think that's our summary of sensory disturbances, how they can manifest, and what things that we can do about it, and I'm open to any questions.
Okay, so that was a great overview about sensory disturbances. I want to thank Dr. Hu for taking the time to share with us. I see some people have started putting some questions out there, so I invite you to now start just putting in the chat box, okay, in the Q&A session, the questions that you want to have. And as promised, right now, I'm going to introduce you to Dr. Nancy Hu. Hi, Dr. Hu.
Hello. Thank you, Dr. Serrano, for
the introduction and for sharing your wonderful design work and producing this video. So I feel very privileged to be able to continue this conversation and address some of the questions and answers that may have stemmed from the conversation about sensory disturbances and MS. So I'm going to just kind of go through the Q&A section and bear with me. The first question, noticing a visible red spot on one knee that feels hot internally as well as with touching it. Just a random sensation that can be part of MS. I think it's meant to be a question. So taking a step back, typically the nerve complaints when it's related directly to MS damage to the brain and spinal cord are actually not associated with any skin changes. Though when there are skin changes that might actually signal maybe something going on, with the peripheral nerves, right? That again, those receptors perceiving some type of irritant, and especially if there's redness, swelling, there might be internal inflammation, external inflammation going on that actually may just be kind of additive to existing nerve complaints related to MS. So it definitely can add on to it. So these are things that are really worthwhile in terms of following up with the MS providers, kind of sort things out because, unfortunately, even with the diagnosis of MS, it does not make us immune to other types of conditions. A second question, I have pain that is worse with seating. Is this because of MS or because I'm 60 years old? So again, a really great question. I think what can help is kind of working with the provider to kind of provide more descriptions of the pain, right? That can discern whether or not it's MS or plus minus some age-related arthritis changes that can happen. So when kind of going to see your provider, it's very helpful to kind of provide, when things started, if there was any type of trauma or inciting event that may have provoked the symptoms. If anything had happened like this before, and what your responses were to certain types of therapies, that can also kind of help us figure out if it's more MS sensory disturbances or arthritis or even other types of conditions that cause pain. Timing, whether or not things kind of come and go or whether or not they're a little bit more chronic can help us tease it out. Definitely pay attention to what makes it better or worse, right? Especially certain positions, or if resting makes it better. Those can also help us determine whether or not it's age-related degenerative changes or related to MS. The third question, is headache a symptom of MS? So again, with MS, neurological symptoms can manifest as it relates to different irritation of parts of the brain or spinal cord. It's really hard because whether or not it's directly due to MS or whether or not there's just other existing migraine history, tension history, even different cluster types of headaches, all because they affect the brain, it's still something that we need to prioritize and something that we definitely need to discuss during our neurological appointments. Again, in terms of the headache, it's very helpful for the types of descriptors to kind of sort out maybe how it can be best managed in terms of if we need, medications to be taken every day to prevent them, to kind of lessen the duration, lessen the severity, or even the frequency, or whether or not it's something that we just kind of take as needed medications. So it's hard because with headache, there's so many different precipitating or provoking factors that might bring them on. So paying attention to what those are and bringing that to the doctor's appointments, we can very much help sort out. Another question, my immobility as well as isolation, largely due to COVID pandemic, are the biggest obstacles for me. I do have discomfort and muscle spasms, and I pray frequently for this. And this has helped me, so praise the Lord. Okay, so yeah, my heart goes out to you. This past year has not been easy for anyone, especially those with chronic conditions who already feel a little bit trapped, especially with not being able to go out, right? It kind of speaks to the pain cycle slide that we had earlier in the talk, where when we already have pain and if we're not kind of mobilizing
retraining the brain, spinal cord muscles, and kind of engaging and triggering endorphins, those feel-good, neurochemicals, it can just kind of be harder and harder to move. Then with muscle inactivity, then the muscle tightness and muscle spasms then continue on. Then you pay attention more to it. Then you're feeling more pain, and then it's just this endless cycle. So I'm glad that for this individual, you've been able to find comfort and being able to take a step back, and knowing that hopefully there's mitigating factors, right? And again, speaking to the mental effort, the physiological effort to kind of keep things at bay. Okay. Another question, once diagnosed with relapsing remitting MS, if opting out of disease-modifying therapy, how often should you get an MRI to see if more lesions have developed? So again, even though this is a sensory disturbance talk, I think where we have to always kind of bring the conversation back to, right, is how are we treating the underlying disease? So there are many different ways of going about that to kind of change the immune system. So whether or not we're on disease-modifying therapy, many people use lifestyle like exercise and supplements, even anti-inflammatory ways of eating to kind of help get things under control. Again, that's a very individualized discussion with the provider. In terms of MRIs, they are our best biomarker to kind of supplement how the disease is being managed, right? Because during appointments, we're definitely asking patients, how are you feeling, right? As one point of comparison. We do the examination to kind of figure out if we can have objective data of even new symptoms or progression of symptoms. And then the MRI, it's hard because not all lesions always show up, right? Because there's a lot of redundancy in the brain, especially to kind of, even if there's sites of injury, to kind of go around it. So you don't always get that either with symptoms or based on exam. So again, for MRIs, it depends. Some providers order them every 6 months in the beginning. If it's really early on in the disease, sometimes it can be every 12 months. But I think this is one of those where I don't want to. There is a range, okay? And I think it also depends on how clued in a patient is in terms of monitoring their symptoms and active in communications. Okay, another question about what about feeling generally itchy? I have been taking Benadryl and it seems to help. Yes, so with neuropathic or sensory disturbances, they can really manifest in a wide range, right? It could be hot, cold, it could be creepy, crawly, it could be electric. Itchiness can also be a complaint. It kind of depends on where specifically, like whether or not, it's one-sided or all over. If Benadryl is helping, that kind of signals, yes, there's some type of inflammatory response going on. So whether or not that's due to MS or, another question I would kind of offer is whether or not we're on any types of medications or other external factors that might be priming that kind of histamine reaction. So again, this would be a good question to check up with if you have any patterns. Also paying attention to if there's any like rashes, right, that are associated with that itchy sensation. And other, like if there's any weakness in the affected areas, those are helpful things that as a neurologist I can help tease out. Okay. If pain moves to different parts of the body, leg, then wrist or neck, for example, should I change medication with each change? Right. So I'm not sure if this relates to like symptomatic management of medications, like the different antidepressants or anti-seizure medications. It's really hard because I know I'm trying to kind of keep up with the different affected areas. I think what's important is, again, the descriptors of the pain, right? If they're moving, but they're different qualities, that actually might signal there's different causes going on. So yes, that might actually beckon, changing in medications. But even within classes of medications, there's also different doses, right? Where maybe, there's a lower grade sensation in the arm that we just need higher titration up in certain other parts. These type of things are reasonable, I guess, topics and things, details that would help. Okay. And The next question, any help from acupuncture, chiropractor, and PT? So yes, so in terms of non-medication ways of treating the pain, right? It can be very helpful to just pay attention to the body and kind of retrain the mind-body connection. So acupuncture is thought to kind of promote kind of the flow of lymphatics. So there maybe is not as built up of toxins. Sometimes people attempt cupping. It's hard because there's no like dedicated studies per se yet, but I am aware that they are trying to look into specific acupuncture protocols specifically for MS-related complaints. Chiropractors can definitely be helpful if there's musculoskeletal symptoms, on top of existing MS sensory disturbances. They sometimes kind of realign the neck and back area. In general, again, I don't want to overspeak and overgeneralize, but in the neck, I try to refrain from doing too much chiropractic manipulation just because there's a lot of high value real estate connecting the brain to the rest of the body, major blood vessels, the spinal cord. Some young people can even develop strokes when there's too much kind of jostling of this area. So if we're going to do chiropractor, I try to limit to kind of below the neck. Otherwise, physical therapy can definitely be helpful in terms of, using our understanding and knowledge of the anatomy, right? Especially if there's kind of, besides sensory complaints, muscle complaints, range of motion exercises, stretching to kind of help loosen the muscles, pulling on the nerves can be very beneficial. Sometimes dry needling, basically trying to insert a very thin filament to kind of break down the outer coating, can actually provide significant relief. So in terms of which modality, again, it kind of varies depending on how severe things are, but I definitely have had patients who benefited from any one of the three. How closely related are active lesions and sensory disturbances? And then can I experience sensory disturbances when I have no active lesions, right? So this is why, in terms of when things happen, it's important to kind of communicate with your MS provider, because when lesions happen in certain parts, the sensory disturbance can be very clear, right? Especially if it's the somatosensory cortex in the brain. Sometimes within, parts of the spinal cord, you can have direct one-to-one relationships. With the sensory disturbances, otherwise that have no lesions, that also could be possible because again, kind of thinking about the anatomy of the sensory pathways, it's not just the brain and the spinal cord, right, that are responsible for the processing, right? We also have peripheral nerves, the little ones that kind of sense everything and then signal their message upwards. So sensory disturbances can also be the result of, diabetes, even thyroid dysfunction, B12 deficiencies. So even those can cause sensory disturbances that do not actually indicate any active MS lesions. But again, whether or not you notice any other symptoms, motor complaints, weakness, imbalance, cognitive fog with these symptoms, the timing, all of these can help us sort it out. The next question, in general, what is the most effective treatment for an MS hug? This happens to me out of nowhere in the evening and can affect my sleep. I'm so sorry. I can only imagine what it's like to feel like that squeezing, tight sensation, and the type of panic that can cause, especially when it happens out of nowhere. So with MS hug, sometimes it can be the result of kind of the sensory nerves being disrupted. Sometimes it can actually be the result of spasticity or the muscles kind of tightening up. There's a variety of different treatments that are worthwhile to explore. Certain antispasm medications might be helpful, but unfortunately, MS hug is one of the more kind of difficult to treat sensory disturbances. But it is worthwhile to kind of explore other muscle-related medications that are actually outside the scope of this talk as well. Okay. All right, the next question, does a type of pain often change over time with MS patients, or do pain sensations usually stay pretty stable? For example, the first year's diagnosis, one experiences mostly tingling and pain, and down the road they start to experience spasms. So, one of the fundamental truths of life is that things change, right? So things evolve. And the kind of tingling sensation, the tingling pain kind of tells me it's more maybe the sensory pathways, but then sometimes with spasms, right, that's more of the kind of the muscle. So it's hard often to kind of tease them out, but they can co-occur. They can just kind of be additive as well. And I think that's why, providing such good descriptions help us be able to, as the sensations evolve, we evolve in terms of our treatment. Especially kind of thinking about, sometimes with complaints, they can just improve. Sometimes they can worsen. That's why it's important to kind of monitor these responses to see how else we can kind of affect and change. Okay. I don't think you mentioned itching, but I do have a fair amount of cutaneous itching, especially in the waist area. No rash or no obvious external trigger. Okay. So again, itching can be a sensory disturbance. And then in terms of what it responds to, glad that there's no rash and other external trigger, like any changes in soap or anything like that. So it potentially could be related to kind of nerve dysfunction. But again, trying to work it out with the provider, seeing whether how this could be treated. Okay. The next question is Gilenya a good and safe MS medication? So I'll kind of take a step back. Each case of MS is a little bit different as it relates to symptoms, exam findings, and disability and MRI. So, Gilenya is commonly used, widely used, safely used. And again, this is a good conversation to have one-on-one with your provider to see if it's a good fit. Do you recommend getting the vaccine with MS and MS medications? So I think this relates to the COVID-19 vaccinations now that there are 3 available out, the Pfizer, Moderna, and the Johnson & Johnson. So again, this is, during routine appointments, this is a regular point of discussion, right, to kind of think through things. But based on the technology of the available COVID-19 vaccinations, we do think that they are compatible with MS. We do not think that they cause any types of relapses or such severe surges in inflammation that cause new activity. But again, it's very individualized decision. However, a lot of patients have been getting it and been responding well without any sequelae. So, and in terms of use with medications, the specific disease-modifying therapies do, it's really case by case in terms of even timing and then the overall efficacy. So again, I have to point us back to our specific conversations with our MS providers. Okay. What treatment for MS has helped patients the most? Again, I wish I had a good answer that would work for everyone, but unfortunately, everyone comes from a different baseline. Everyone is willing to take on different risks, so it's hard for me to give such a generalized answer. This doesn't have anything to do with pain issues, but how effective do you believe the COVID-19 will be on those of us with more aggressive therapy options, in my case, over this? So again, we are doing clinical trials now to kind of be able to answer this question specifically as our disease-modifying therapies are affecting our responses, right? The protective responses to the vaccines. We are paying attention to this. At this juncture, we don't have any reason to think that we would not develop any type of benefit. But again, to have a conversation, okay, to kind of think through. But big picture, if it's safe and can keep you out of the hospital in terms of potentially life-threatening consequences from the COVID-19 vaccine, I would kind of, put that at one end of the scale compared to the very negligible kind of theoretical risks as it relates to MS. Okay. Next question, I've been taking gabapentin 200 milligrams in the morning and 200 milligrams at night, and now they have added another 200 midday. So yes, gabapentin is one of the very widely used medications for neuropathic complaints, again, acting on those calcium channels. how a provider starts medications kind of depends on what their experiences have been, because sometimes even with gabapentin 100, like my husband took it for like back complaints and it knocked him out, whereas other people start at 300 3 times a day and it doesn't even affect them. So some of us start kind of low, titrate up slow to kind of monitor the effects, because obviously we don't want to, you know, scare anyone off of the medications by making them too drowsy. But you know, 200 milligrams 3 times a day is actually a reasonable dose. Some people again start at 300 3 times a day, but some people are up to 1200 3 times a day. So again, there's a really big range in terms of how we can up titrate that medication to make sure that the sensory disturbances are not bothersome. Okay. And someone mentioned I had logon issues. Will this be available to watch later? So my understanding is that yes, the pre-recorded section and this Q&A will be available for other people to access later. Okay. Another question is there any truth to switching to Ocrevus, that there can be some improvement in pain and sensory symptoms? So with our disease-modifying therapies like Ocrevus, right? The main goal of them is to prevent future relapses, future new lesions, and maybe even kind of slow down progression by kind of calming down the inflammatory state. I try to be very cautious about kind of promising any reduction in symptoms per se. You know, I cannot not say that, you know, some symptoms might just get better. Just because there's also additive changes, right? Symptomatic management in addition to disease-modifying therapies, or even if there's lifestyle things introduced. But I try not to promise any kind of reversal of pain or sensory symptoms. Can you discuss the on and off sensory disturbance issues on the face or scalp area, like tingling and spasms? So yeah, again, these type of sensations can definitely be very individual as it relates to prior existing injuries in the brain and spinal cord, and definitely if anyone has other peripheral nerve factors like even diabetes, again, B12 deficiency, B6 toxicity, those can definitely be additive. For on and off sensory disturbances, again, depending on how bothersome they are and how long they last, there are ways to kind of treat it. If it's very kind of superficial, maybe this would be an opportunity to discuss topical medications like even menthol or capsaicin, or if there's kind of spasms associated with it, like topical anti-spasm compounds, to be able to target it without the whole systemic effects. But again, in terms of on-off things, kind of paying attention to, you know, what brings them on, and avoiding triggers can help. But definitely, if we're trying to look for more localized effects without this whole systemic side effects, I think topical compounds may be helpful. But again, it's also different if you have like a deep jolt related to, you know, trigeminal neuralgia, where maybe anti-seizure medications might be more helpful, again, depending on how debilitating they are. Maybe. I hope
All right.
this has been helpful.
Yeah, no, I think it's, oh, wow. Let me see, there's more.
Okay.
Okay. There we go.
Okay. Okay, the next question is tolterodine. 2 milligrams is a good medication to help with urinary issues like frequency. So it is a medication used, again, but in terms of side effects, good thing to kind of discuss with the provider. There's a range of dosing, but it is commonly one that we use. Okay. Does exercise and dieting really help improve MS symptoms? I really believe so. So that's why, in terms of like, if I wish I could prescribe this to be able to help, I wish that I could, but pharmaceutical companies can't make money off of that. But even as it relates to exercise, right? The whole premise is that even with aerobic activity, let's just say cycling, walking, you're increasing blood flow, right? So if you're increasing blood flow, you are pumping more blood to those nerves, feeding them oxygen, the nutrition that they need, and actually circulating the endorphins that act as their own kind of natural painkillers in a sense, right? And again, making sure that we're exercising those muscles and feeding the nerves, then we're also forcing signals up to the brain and spinal cord, so kind of exercising this, organ system. Can definitely be very beneficial. And it just kind of, again, it helps you feel good, your body feels good. So it's kind of reversing that kind of pain cycle where then you're not maybe necessarily paying so much how uncomfortable you're feeling, but how good you are. And then that internal drive, feeling empowered, like you're doing something, can be very beneficial. Dieting, again, so no one diet is the best aside from the one that you stick to. There are certain anti-inflammatory ways of eating that can be a part of the wellness. But again, anything that kind of slows down the aging process, right? The degenerative changes that just happen day to day, that improve the mind-body connections and make us feel like we're a little bit more in control, can be very helpful in this disease process. Another question is, what are adjectives that are clues for specific pain sources, right? So things like, pins, needles, or tingling, might signal kind of nerve irritation. If it's like achy, then maybe, or tightness, maybe that's a little bit more muscles. If it's like deep, some people actually describe like bone pain. That can actually point to different sources as well. If it's sharp, if it's that can kind of signal to different ways. Throbbing sometimes can signal, like vascular changes. So those are some descriptors of what source the pain might be stemming from. But ultimately, the best words are the ones that you use, right? Like if it's pain that's kind of like dragging you down, making you feel like quicksand, or I'm just trying, I'm coming up at a blank, but any ways that you can kind of describe are ways that we can kind of bridge. I don't have a question, but I just want to thank you. So thank you so much for you guys paying attention and asking really great questions to be able to again, increase your control of knowing what to do and how to take action every day, right? Because us as providers, we're only one piece of the recipe, the formula to be able to do well. Very conscientious that you guys do the day-to-day in terms of dealing through all the symptoms, feeding us back the information so that we can make well-informed decisions. So my feet are always cold, especially at night, and my fingers also turn white with rain on. So any treatment. So again, this also kind of beckons to how other peripheral nerves, right, and even kind of Raynaud's with kind of like the blood vessels shrinking, so not delivering blood flow all the way down to the fingertips, making them feel cold. They can be treated, but again, a little bit out of the scope for this talk, unfortunately. Okay. So next question. Okay. All right, so that one's about the COVID-19 vaccine, which I think that we talked about. Another question, would gabapentin help me with tingling in the feet? Potentially it could. So again, trying to also take a step back and making sure there aren't reversible causes for tingling, working with your neurologist, but then in order to kind of put Band-Aids on the symptoms, especially if the tingling are interfering with like being able to sleep, being able to walk or do the day-to-day, gabapentin can be helpful. It can be used as needed when things kind of flare up, or it can be taken every day at night. It can be taken twice a day, 3 times a day, 4 times a day, depending on the severity of the complaints. Okay. Okay, and I think the last comment, thank you so much to both Dr. Hu and Dr. Serrano. I look forward to our next seminar. So, thank you.
Closing arguments? Yeah, all right. Okay, so let me just join in. Okay, so you might say just goodbye to them.
All right. So again, thank you everyone for your very involved questions. Again, I feel very privileged to be able to work with such educated and very empowered individuals, and looking forward to seeing you at our other educational seminars. At this point, I will bump you guys back to Dr. Serrano.